Ever felt like medical concepts are too complex to grasp during a rushed doctor's visit? Many patients do, and end up lost in the vast internet seeking clarity. At VidOCO, we believe medical information should be both clear and personalized. Our platform, crafted by surgeons, offers a library of peer-reviewed consent aid animation videos that break down surgery step by step. But here's where we stand out. Each video can be tailored to individual patient needs. Whether it's explaining a specific surgical procedure, its benefits, or potential risks, VidOCO ensures that every patient receives a customized video. Imagine a patient understanding their surgery on their own time, rewatching the content, and sharing with loved ones. We ensure your gold standard talk reaches them directly on their personal devices. And yes, for our Spanish-speaking patients, we have a dedicated Spanish library. Our commitment? Enhancing doctor efficiency, improving patient understanding, and bolstering informed consent documentation, all while being HIPAA compliant. Contact us to get started today.
The intestinal tract is as follows. Food travels from your mouth to the stomach, then into the small intestine, which eventually empties into the colon, in the right lower abdomen. The valve between the small bowel and colon is called the ileocecal valve. The very first portion of the colon next to the ileocecal valve is called the cecum, and the appendix is a long hollow outpouching from the cecum. The colon then runs up the right side of the abdomen, and is called the right colon. The colon turns at the liver, which is called the hepatic flexure, and runs across the abdomen, and this portion is called the transverse colon. It turns again at the spleen, which is called the splenic flexure, and runs down the left side, which is called the descending colon. It loops an AS shape before entering the pelvis, and this section is called the sigmoid colon. Once it enters the pelvic soft tissue, it is the rectum. The colon is in the sac of the abdomen that contains the abdominal organs, whereas the rectum is surrounded by the fat and muscles of the pelvis. At the end of the rectum is the anal canal and anal opening. The term for cancerous cells that start inside the colon is colon cancer. Sometimes, colon cancer can start as a small growth on the wall of the colon, called a polyp. The reason that colonoscopies are performed is to look for these polyps. If a cancer develops, however, it has the possibility of growing through the wall of the colon and spreading to lymph nodes. Lymph nodes are part of the immune system and are all over your body. In cancer, the cancer cells tend to spread and stick in the lymph nodes as the first location of spread. In colon cancer, the lymph nodes run near the blood vessels feeding the colon. It is important that the doctors evaluate the lymph nodes to see if colon cancer has spread to them. If there is cancer in the lymph nodes, then the stage of cancer and treatments, such as chemotherapy, will be different. Laparoscopic surgery, also called minimally invasive surgery, is a technique for surgery that uses small incisions on the abdomen. This decreases postoperative pain and improves recovery. The patient will undergo general anesthesia because the abdominal muscles must be fully relaxed. The surgeon will make several small 1 to 2 centimeter long incisions in the abdomen, place long skinny tubes called ports through these incisions and through the abdominal wall muscles until the tip is in the abdominal space. The abdominal space is inflated with air to allow space to work, and long, skinny instruments, along with a tiny camera, are inserted to visualize the internal structures. The surgery is performed using the laparoscopic instruments controlled by the surgeon, but the surgeon does not need to place their hands into the abdomen. In a laparoscopic sigmoid colectomy for cancer, the patient will undergo general anesthesia before the surgery begins. The surgeon will make several small incisions in the abdomen, inflate the abdominal space with air, and insert specialized instruments, along with a tiny camera, to visualize the internal structures. The sigmoid colon is the portion of the colon in the left lower abdomen. It is the last part of the colon before the rectum. If there is cancer in this portion of the colon, it is important to remove the lymph nodes that are attached to the portion of sigmoid colon. The sigmoid colon is identified and freed from any surrounding attachments. The colon above the cancer is divided with a stapler device. Then the colon or rectum below the cancer is divided with a stapler. Blood vessels going to the colon are divided with surgical tools. The area of the colon, with the cancer and the attached lymph nodes, is removed. To reconnect the colon to the remaining rectum, a round stapling device is used by the surgeon to attach two pieces of bowel together using small metal staples. The top of the device, called an anvil, is placed into the upper portion of the colon. Then the handle of the stapler is brought through the bottom and into the rectum. The two ends of the stapler are attached, and the stapler is fired to make a round reconnection of the bowel. Food can then once again pass through the colon, and through this new reconnection and out of the anus and bottom. The portion of the colon as it turns in the upper, left abdomen, near the spleen, is called the splenic flexure of the colon. There are bands of tissue that attach the splenic flexure to the stomach, the spleen, and to the muscle of the left abdominal wall. These tissue bands are divided to free up the splenic flexure. This is done to allow the colon to reach further into the lower abdomen area called the pelvis, usually to help reconnect it after a portion of colon, or rectum, has been removed. During surgery, if the minimally invasive technique is not safe or possible, the surgeon may need to make a bigger cut to place their hands into the abdomen. The skin is cut, then the muscles and fibrous tissue of the abdominal wall is opened, usually in the midline of the abdomen. This is called open surgery. The tubes that carry urine from the kidneys to the bladder are called the ureters. These two urine tubes are in the tissue, in the back of the abdomen, and are close to the colon, especially on the left side. During surgery around the colon or rectum, accidentally damaging the tube can lead to leakage of urine. Damage can also cause scar tissue that can affect kidney function. Additional procedures, or a change in the surgical plan, might be needed if the ureters are damaged. The bowel, or intestine, are nearby during any surgery inside of the abdominal space. The surgeon takes many precautions not to damage the intestine. Rarely, an instrument, a trocar placed through the abdominal wall, or electrical energy from the tools used in surgery, may cause a hole to form in the bowel wall. If this occurs, bowel contents can leak out, leading to sickness. Bowel injury often requires additional interventions, or more surgery. Using modern techniques and special tools, this is a rare problem. In abdominal surgery, bleeding can occur during or after the surgery. The bowel has blood vessels flowing to and from it, carried within the fatty tissue connected to the bowel. While surgeons employ meticulous techniques, such as cauterization or sutures, to minimize this risk, bleeding is an inherent possibility with any intra-abdominal operation. If there is a large amount of bleeding, the patient may need repeat surgery or blood transfusion. After surgery in the abdominal space, the surgeon might be concerned about fluid accumulating. This fluid could be blood or other bodily fluids. The surgeon can leave a drain during the surgery to help remove this fluid. These are long flexible tubes that have holes in the end. The portion with the holes lays inside the abdomen. The other end of the tube exits through the abdominal wall and is secured with a stitch on the skin. The outer portion of the drain tube is connected to a bulb. When the bulb is compressed, with the plug in the top of the bulb, it will suck fluid out of the abdominal space. The patient will need to empty the bulb daily and record the output. When it is ready to be removed, the stitch holding the drain is cut, and the drain slides out easily, and with minimal pain. During surgery of the colon, the new reconnection of the colon is often performed using stapler devices, or, occasionally, stitching. The new reconnection of the bowel can sometimes be deemed by the surgeon to be at higher risk for possible poor healing and leakage of bowel contents. If this decision is made by the surgeon during the surgeon might decide to divert the bowel contents away from the colon by bringing a loop of the end of the small intestine up to the skin. The loop of small intestine is open on the skin surface and stitched in place so that the bowel contents come out of the small intestine into a bag and do not ever enter the colon. Since the end of the small bowel is called the ileum, this procedure is called a loop ileostomy. Usually, an ileostomy is temporary, and once the colon downstream has healed, another surgery can be done to reconnect the small bowel together and place back inside the abdominal space. After that, the patient will go back to having bowel movements out of the bottom. The spleen is an organ in the upper left abdomen. It is about the size of 2 fists and plays a role in producing parts of the blood, and it also functions as part of the immune system. The colon runs near the spleen and has some fibrous attachments to it. These attachments are sometimes divided in order to free the colon during surgery. If damage to the spleen inadvertently occurs, this can cause bleeding. If the bleeding does not stop, the entire spleen may need to be removed. Pain after surgery varies amongst patients, but some discomfort is expected. The surgeon will discuss the plan for pain medication with the patient. After 1 week, using over-the-counter pain medication should be sufficient. It is important to take stool softeners after surgery to prevent constipation, especially if narcotic pain medication is used. The reconnection of the bowel is called the anastomosis. If this reconnection does not heal properly, bowel contents and infection can leak out, causing sickness. This will often require additional procedures or surgery. The risk of anastomotic leaks is less than 1 in 100 for right colon surgery, and less than 1 in 10 for surgery of the left colon and rectum area. After surgery, the intestinal system can go into a state of shock and move slower. This can lead to a feeling of bloating and, in severe cases, throwing up. This is called ileus. Ileus will resolve on its own after a few days. Using less narcotic pain medication and walking will help this resolve faster. After surgery inside of the abdomen, bacteria can form a collection of pus, called an abscess. The bacteria can come from infections in the abdomen, or from leakage of bowel contents, or other body fluids. The abscess may need antibiotics, drains, or repeat surgery. Minor bleeding from vessels in the abdominal wall, or skin, can occur during, or after, surgery. This bleeding can be stopped with specialized tools such as clips, stitches, electrical cautery, or vessel sealing devices. Minor bleeding very rarely leads to the need for blood transfusion. A hematoma is a collection of blood that forms after a surgery. Symptoms of a postoperative hematoma may include swelling, pain, redness, warmth, and a feeling of fullness or pressure in the affected area. Blood may ooze from the incision. A bruise may be visible on the surface of the skin and may take several weeks to slowly reabsorb. To prevent postoperative hematomas, it is important to avoid certain medications that can increase bleeding risk and to follow the postoperative care plan, such as limiting physical activity and avoiding strain on the surgical site. Wounds can sometimes reopen after surgery. This is called dehiscence. This is more common if there has been an infection or a blood collection called a hematoma. If a surgical cut reopens, it will take longer to heal and will often require wound care at home. Risk factors for healing problems include obesity, diabetes, and smoking. The abdominal wall is made up of muscles and sheets of fibrous tissue, called fascia. Any surgery that divides the abdominal wall can lead to weakening of these structures. The surgeon will recommend the patient does not lift more than 20 pounds for 1 month after surgery. This allows the abdominal wall to heal properly. If the muscles and fascia do not heal properly, they may form a hole that allows a bulge through the abdominal wall, called a hernia. This can be dangerous if it pinches the bowel in the hole, causing blockage or damage to the bowel. Hernias are often fixed to prevent this problem. Hernias do not resolve on their own and tend to grow over time if not surgically fixed. After surgery in the abdomen, scar tissue can form. This scar tissue might never cause any problems. But the intestine, particularly the small intestine, can sometimes get kinked or blocked by this scar tissue. If this happens, it is called small bowel obstruction. This can occur weeks or months after surgery, or it might be many years later. Small bowel obstruction from scar tissue is less common if minimally invasive surgical techniques are used.